let's see.
Rotate your device.
Well, that is some light, I'll tell you that
Oh,
much.
it's got to go.
I know. Makes your skin look better than it is, though, I think.
It's like one of those TV tricks.
Yeah,
All right,
exactly.
we are live now. All right, let's see. Where is the light? Hey, everybody. We're going to get the light adjusted here for a second. Stephen, could you twist the light just a little bit so we are both here? Yeah, turn it that way. All right, I think that's better. And I'm going to have scoot over here. There we go. Hey, everybody. This is Dr. Eric Potter from Sanctuary Functional Medicine, where we help patients live healthier, more abundant lives. As promised, we are going to be spending the next hour answering some questions about hormones. Beth York, our newest team member, hormone specialist, nurse practitioner, is going to walk alongside me in a little bit of a dialogue. I will talk about some of the ways that functional medicine approaches it, getting rid of inflammation to help hormones, getting rid of toxicities, and she is going to work in that. Everybody, I think we're sideways, so we're going to turn ourselves. And back.
That's great.
Not really. All right, thanks everybody for putting up with a little technical difficulties we have in here. There we go. So we're just going to have to be... Stephen, does that look better on the screen? Yes, there we are. All right. So as I was saying, we're going to talk about a functional medicine and bioidentical hormone approach to a lot of patients' symptoms that we see on a pretty much daily basis. So one of the first things I do want to say, though, is if you are listening and you are feeling like some of these things apply to you, we do recommend that you do not take this into your own hands, but you make sure that you are being guided by someone else, especially when it involves adjusting hormone dosages or adding a new therapy that could potentially maybe help one illness or one symptom, but potentially cause other side effects or interfere with other medicines. So do get some help in guiding your therapy changes. We're here if you need that, but if you have a local practitioner, you can always ask them about this. So with that in mind, again, Beth York, she has joined us here in the last few weeks. She is certified in bioidentical hormones. I'm going to let her tell you a little bit about her certification process in just a moment. She can give you those details. But we're going to do a dialogue. Basically, we have some questions that some of you have sent in. We also have some just common topics that come up as we care for patients, whether it's their estrogen, progesterone, testosterone, symptoms that they have that they don't know, they don't realize could be related to hormones. So first of all, Beth, I would like you just to tell us a little bit about your training and a little bit about how you came to take care of patients with hormone imbalances.
Well, my original master's degree, or MSN, Master's of Science in Nursing, is from Vanderbilt University School of Nursing, actually with an acute care focus. And quickly learned that I really wanted to treat a different demographic. You're only allowed to do ages 18 and up in acute care in the state of Tennessee. So I got a postmaster's in family practice, and I took a position where I didn't know they had hormone patients, and so they graciously offered to send me to training. I went to part 1 in 2014 in Salt Lake City, Utah, through WorldLink Medical, and that was 23 hours. Probably the hardest training I've ever sat through, but fascinating too. And then it just sort of built from there, and I did parts 2, parts 3, parts 4, and then I sat for a specialty certification through WorldLink Medical. So the specialty certification is Advanced Bioidentical Hormone Replacement. And I've taken care of well over 1,000 hormone patients, all ages, but I will say that most of them are probably ages 35 or 40 and up. Really interesting because hormones just impact so many different facets of somebody's health and life. So I've been doing that for 4 years and really love it. Always something more to learn too.
Yes. There's always more to learn in this field, and if you've learned it all, then tomorrow they're going to come along with something new that you didn't know about.
Yes,
so,
they are.
So again, we're going to be answering questions about hormones. We're going to start off with some that patients or just listeners have sent in. I do want to let you know that towards the end we are going to address a little bit about the effect of mold toxicity on hormones, but we're going to save that for the end because that is a little bit of a specialized talk in itself. So I'm going to go down and just share some questions, and I'll ask the question. I'm going to add a little bit about how functional medicine approaches that. Then I'm going to hand it off for Beth to finish how she would kind of balance hormones using bioidenticals. So this is a patient that's been working with me for the last few months. Thyroid's better, feeling better overall, but she's saying that she's been on bioidentical hormone replacement for 4 years and conventional hormone replacement for 5.5 years before that, so about 9.5 years due to an early menopause, which occurs frequently. So she's now 55, so about the age of 45 she started going into menopause, and she's asking whether or not she should consider tapering off bioidentical hormones. So she's asking why should she stay on them now that she's been past that age for 9 or 10 years, and that this is kind of the time, mid-50s, her body was making that transition naturally. So I'll just quickly say, this is one I'm going to let Beth do most of the answering on, is there are definitely benefits to ongoing hormone therapies. There's also things that we can do from an herbal or vitamin approach to make sure that those hormones do stay a little more balanced. And then we would hand off to Beth to kind of take it, say, what reasons would you give that if she was sitting across from you in an exam room? Would you tell her to say, oh, there's actually a few more good reasons that you should stay on these?
The number one reason I would say is disease prevention. Unfortunately, when we start to lose hormones, we're about 30, 35 when things really start to decline. Most people don't notice until they're 38, 40, and sometimes they'll notice till they're 45 or 50. But when you lose hormones, you lose disease protection. Okay, so the first thing we lose is testosterone. With testosterone loss, you'll get belly fat, weight gain, you'll get fatigue, irritability, moodiness, memory loss, lack of motivation, decreased libido. A lot of women and even men get night sweats, and some get hot flashes actually. And men can get erectile dysfunction, but not all of them get that. So you're symptomatic, but you're also losing powerful protection against heart disease, against prostate cancer and colorectal cancer, against osteoporosis and Alzheimer's, among other things. So disease prevention standpoint from the testosterone is hugely important, but it also makes an enormous difference in how you feel. It's the difference in feeling like when you get up in the morning that you're rested and that you have enough energy to make it throughout the day, and then actually get home and actually walk your dogs and cook dinner for the family and do everything you want to do, and feeling like you're dragging yourself throughout the day, and getting home and feeling like telling the kids to fend for themselves and the dogs will be okay. So that would be with testosterone. But the next thing that women in particular lose is progesterone. And when we lose progesterone, your periods can get really heavy, you can get irritable, you can get more moody. The biggest things with progesterone are you'll get more frequent headaches and you'll have trouble falling asleep and staying asleep. Those are symptoms that not everybody understands or connected to hormones. They may blame them on other things, just like they blame the symptoms of testosterone loss on other things. So in terms of disease protection, progesterone is one of the most powerful things that you can use for protection from breast cancer, also from uterine cancer, from osteoporosis and Alzheimer's. And then the last hormone that women lose is estrogen, and that's considered menopause when estrogen is gone. So when you lose estrogen, your risk goes up hugely of heart disease primarily, but also of colorectal cancer, a little bit risk of breast cancer, but then of sarcopenia, which is skeletal muscle loss due to hormone loss, which increases your risk greatly for falls as you get older. So Alzheimer's and osteoporosis are also connected to estrogen. So, a lot of people come in and they'll say, I'm not really symptomatic, I've gone through the change and my hormones have kind of settled down now. What they don't realize is when they lost the hormones, they lost that disease protection. So we want to work from a perspective of preventing disease, not just treating disease or throwing a pill at it or putting a Band-Aid on it. So this is one way to really lower your odds, even if it's a genetic issue for you or not.
So basically, there are a number of reasons why that someone would want to continue, and having someone sit down like Beth, sit down and explain what those benefits are, and help you to understand that what you see in the news is not always a full story. And actually, if if you understand the news at all, you know it's never really the full story. So there are definitely benefits, and we see patients who do experience those benefits. Another question one of our patients left was, so for a person who has endometriosis, has had 5 children, just had a baby, doesn't really want to be pregnant again for at least a few years, but wants to keep that endometrial growth from happening, that's been a significant thing for her, doesn't necessarily want to be taking oral contraceptives, which is kind of a conventional approach to that. So I want to start off by just mentioning a few things that we will deal with as far as how endometriosis occurs. So there's a lot of theories, but the old theory was your uterine tissue kind of backflowed and ended up around in your abdomen. That's kind of not really accepted as much anymore. Looking hormonally, tying into a little bit of what I do with methylation, MTHFR, if you've heard about that, is your ability to produce methylfolate to use in your methylation cycle, which then you use for detox, use to control, turn genes on and off. It also helps with your neurotransmitters, and it helps with hormones, which is why I'm getting to it at this point. If you have a COMT enzyme, catechol-O-methyltransferase, that's slow, not functioning normal speed, your estrogen can stick around longer. And you're like, well, isn't that what we're trying to do, is raise estrogen? Well, you want your hormones to be there and turn off, be there and turn off. When that estrogen, especially as it's metabolizing, the 4-hydroxy or the 16-hydroxy sticks around longer and is not methylated, not broken down, that can increase your female cancer risk. So your breast cancer, your uterine cancer, and ovarian cancer. So one of the things we're going to look at, it also increases endometriosis. If your estrogen is staying around too long, that stimulates that tissue, stem cells that are likely floating around in your abdomen, to then implant and turn into endometriosis and cause pain, irregular bleeding, severe pain at times. So we will work with patients to make sure, we'll test, urine test, to make sure their hormones are being, your estrogen, particularly estradiol, being processed, maximize their methylation, and look at making sure they've got enough magnesium to help that enzyme work. There are also some other herbals that will help shift your estrogen down to the 2-hydroxy pathway, which is much safer, versus the 4-hydroxy, which increases your risk for cancer. But you still want a little 16-hydroxy, so that way it protects your bones. That's one of the ones that contributes to osteoporosis as women age. So from there, though, those are some of the starting points, helping with inflammation, methylation, magnesium, balancing those things. What are some of the things otherwise from bioidentical hormone standpoint that you could use to help that patient? Sounds like both deal with some endometriosis in a way that doesn't increase her getting pregnant again risk.
So one of the simplest things that you can do is take micronized progesterone. Progesterone and estrogen sort of work in tandem, and if estrogen levels are up here and progesterone levels are down here, you're going to get more of a buildup of the endometrial lining, the lining of the uterus. So one of the best things in the world to do is just take progesterone every night. Now, it's not going to give you any birth control, so you need to discuss that and figure out what you want to do for birth control. It's not going to hinder you from getting pregnant in any way. You can take it on days 12 or 15 through days 26, or you can take it continuously depending on what your goals are and what your needs and symptoms are. But it's a great way to help the symptoms of endometriosis, but additionally to give you disease protection that you would be lacking otherwise. So specifically from uterine cancer, breast cancer, osteoporosis, and Alzheimer's from progesterone.
Excellent. So combining those two approaches, we can help those patients prevent or deal with symptoms of endometriosis. So just want to pause for a minute before the next question and just remind patients, or remind you who are watching as you're coming on, this is Dr. Potter and Beth York, our certified hormone specialist, nurse practitioner that just joined us, and we're talking about hormones. We've talked a little bit about endometriosis, about why a woman would want to continue menopausal, postmenopausal hormone therapy, and we're going to be continuing answering some more questions, but our goal here at Sanctuary is to help patients who are suffering from chronic illness live a healthier, more abundant life. If you have questions about our programs, about how you can get plugged in with one of our comprehensive programs, or get plugged in with bioidentical hormone program with Beth, please give Stephen or our staff a call at 615-815-5941. He'll be glad to answer your questions, but for right now we're going to move on with some more clinical questions. Another question that we got was from a patient. She's 39. She can tell that she is starting into perimenopause. She had her anti-Müllerian hormone tested and was told that she is pretty much guaranteed that she is heading into an early menopause. She has just had one period in the last 5 months. She's eating clean, she's avoiding toxins, doesn't drink, doesn't smoke. Not really sure why she's going in early menopause since her mom did not do that. And she's concerned about that effects for her daughter in the future, if her daughter may be at risk for that. So what are things that she could do, one, that may have put her at higher risk for that, and two, are the things that she can do to prevent potentially the downside of early menopause?
One of the things that's interesting, there was a study that came out not too long ago based out of China, and they studied men between the ages of 18 and 24, 25 that were sperm donors for a sperm clinic, for a fertility clinic. And 15 and 20 years ago, in terms of fertility, 90% of their samples were adequate for fertility reasons, and that rate has dropped to less than 20%. And they were attributing these results to the toxin exposure that we're exposed to every single day. I think unfortunately, fortunately we have more information than we had 15 and 20 years ago when genetically modified food started and toxin exposure is pretty unregulated. I hope to see those things change, but I think the good news is that for your daughter, for your children, you can choose to lower their toxin exposure through choosing safer products, from sunscreen to makeup to shampoo, choosing simple things like not wearing shoes in the house and dragging toxins in from the grass that's all been sprayed, and from the outdoors. And there are a lot of toxin removal things that you can do. For you, I would just continue to eat well, and I would continue to reduce your toxin exposure. Simple other things like not using a microwave. And I would get a thorough evaluation. Just because some labs said that you were in perimenopause, there's really not a map that's really standard in terms of the ability to tell us exactly what will happen to you for the timeline. It is a little bit unusual that you're not following the pattern that your mom does. That's what we tend to see more often. But I really do think it's more related to toxin exposure that we really didn't realize we were being exposed to. It can be other factors as well, but the good news is that you can help with your daughter. I would just encourage you to come in and get labs. We can review your labs, and just because labs say that you're perimenopausal now, it really doesn't mean that you won't still be perimenopausal 10 or 15 years from now. That process on average is about a 10-year process, from about age 40 or 42 to 52 on average. But for some people it starts earlier. I have some people that come to me, a lot of women on birth control in their 20s, and they have the symptoms of perimenopause, and it's because a birth control pill is suppressing their endogenous levels of testosterone, estrogen, and progesterone. So they're tired, they have belly fat, they have no libido, they're not motivated to do anything, they're irritable and moody. And a lot of them choose to stay on the birth control pill, and if that's their choice, then we'll just put them on a low-dose testosterone, and it will fix those symptoms. So I wouldn't consider it all gloom and doom that you're 39 and having perimenopausal symptoms. It certainly doesn't mean that you're going to hit menopause tomorrow or even within the next 5 to 10 years.
So I'm going to keep my comments short this time, and pretty much just second what Beth has shared, and just point out that we have a lot of patients, not just in these conditions, but patients come to us, they're 40, 50 years old, they've got symptoms for the last 5 or 10 years, and they're like, for the last 15 years they've been trying to eat healthy, organic, do all the right things. However, they feel like, what did they do wrong? Well, we all in that age range, I fall into that 40 to 50-year-old age range, grew up around a lot of toxins, and I think our generations were early wasn't the most, but definitely people who are 30 to 40, I think that's when we started seeing that their 5 to 20-year-old range, they were exposed to a lot of toxins and didn't have the recognition. So it may be something that you were exposed to triclosan, a lot of the antibacterial hand soap that has hormonal effects that has now been removed. from those soap products. BPA that they took out a few years ago, it could be something that's 20 years ago affected your hormones, affected your ovaries, affected your testicular function. So we can do a lot now, but sometimes it is trying to, it's not, don't feel bad that your last 10 years of eating organic has not paid off. It could have been a whole lot worse.
It's paid off, just
yes,
not in,
yes.
not as much as you would like, maybe.
Yeah. So, let's move on to another question. Do you always recommend testosterone replacement during perimenopause, or are there benefits in just optimizing thyroid and replacing progesterone? So I'm going to mention a couple of things and then hand this over to Beth for the rest. So anytime a patient comes through Sanctuary, we're going to walk through what we call living matrix. It basically looks at a comprehensive past health history, beginning with your mother's pregnancy with you. So we will look at what kind of health issues she had, what kind of things your father may have been exposed to. I had a patient this week whose father was in one of the worst where they used Agent Orange, and there are some studies showing that Agent Orange can have effects down 1 to 2 generations later. So we'll start there, look at what you've been exposed to, whether antibiotics, mercury fillings, where you lived. If you lived in an area where there's a lot of pollution, we will take that into account, trying to see if you've got inflammation, toxicities, remove those. Sometimes our body is just waiting, once those things are removed, inflammation, toxicities, deficiencies addressed where you're not absorbing well, your body starts functioning well and you don't need other therapies. However, at that point when you say, oh, well, we're 50% better, maybe some of those past toxins from when you were 15 years old are still affecting you, then that's where I'm going to hand over to Beth and say, all right, we've cleaned up all these other things. So Beth, from a hormone standpoint, for a lady perimenopause and asking about testosterone, what are some of the specific benefits that will provide?
Well, one, by optimizing your thyroid, you're lowering, assuming it's truly optimized, your free T3 specifically is in the range that you want it in, you're lowering your risk pretty largely from Alzheimer's, from type 2 diabetes, and from heart disease. So a lot of studies showing huge benefits of optimizing specifically free T3, but free T4 and TSH in the process. And we don't just look at a TSH. A lot of times you'll go for your yearly checkup and they check a TSH and say, oh, it's within a normal limit. Normal is a little bit relative. TSH may be in a normal range, but the other numbers are out of whack. So you're getting a lot of disease prevention from optimizing the thyroid. Progesterone, absolutely. That's primarily protection from uterine cancer, breast cancer, osteoporosis, and Alzheimer's. Symptomatic relief in terms of progesterone, you're going to fall asleep, stay asleep, lower irritability and moodiness, make your periods lighter if you're still having them, decrease headaches as well. When you leave off the testosterone piece of things, for women, typically testosterone is the first hormone they lose. And so when you leave that piece of things off, you're lowering your body's ability to build and maintain lean muscle mass. And lean muscle mass is hugely connected to the number of falls we have as we get older. So you're decreasing your ability to stay safe, really, as you get older. But without testosterone, I have yet to meet a patient that has enough energy, really. That's a big thing. And I see a good bit of mild to moderate depression associated with testosterone loss too. So, you're missing out on feeling better, but even bigger than that, you're missing out on the disease protection benefits of the testosterone.
Yeah, so there's definitely several benefits. And again, one of the Institute for Functional Medicine approaches is to look at adrenals first. So if you're having adrenal fatigue or adrenal overdrive from high stress, we want to balance that because that's going to affect your thyroid and your sex hormones. Then we look at the thyroid and optimize them just like Beth talked about. And then we come down to say, okay, we've addressed adrenal, which includes inflammation. We've addressed thyroid, which includes kind of the speed of your metabolism and how well your body can function and do pretty much everything else that you need it to do. Then we get down to the ovarian and the testicular hormones, and a lot of that work is done, but then again, many patients need that little more because something in their past or their body doesn't completely come back 100% on its own. So it's combining those things together, and we see patients get a lot healthier from that.
And one comment to go back to the lady that said she was eating organically and living cleanly and all that stuff and hadn't noticed benefits. You know, one of the things you have to realize and take into account is, you know, one, you could have hit perimenopause 5-10 years before before you actually hit it. If you hadn't been eating cleanly and eating an organic diet and avoiding toxin exposure and those sorts of things. So you're going to get benefits from it either way. Yeah. But you do have the power to protect your children more than our parents were able to protect us, I think, in our age range. So
yeah. So another question I think a couple of people have left was about Pmdd, premenstrual dysphoric disorder. So for those that don't know what this is, you're probably familiar with premenstrual symptoms, the moodiness, depression, irritability, change in sleep patterns right before a cycle starts. With that, though, some patients can have a very severe, where they are really having major depression, major anxiety spells, panic attacks, and it becomes, you know, if you're cycling every 4 to 5 weeks, 1 to 2 weeks of your life out of every month is disabled. You're not functioning well, you're having difficulty at work, difficulty with relationships in your family. So with that, we see a lot of those patients, and again, we are going to look at toxicities, inflammation, past history, past family history, see were there other women in the family that had similar symptoms, to know, okay, your body's not functioning. We may look at genetics. Again, the COMT enzyme affects both hormones and neurotransmitters. We may look at MTHFR, which affects your methylation, which affects, again, neurotransmitters, which then affect your MTHFR, also affects COMT, again, back to your hormones. You notice there's a little bit of a web here that everything, it's kind of like that old game, 7 degrees of separation, that if you look hard enough, just about all our metabolism, all our functions in our body are connected a few steps away from everything else. So when one thing's affected, this over here, it's a spider web. You touch here and it wiggles over here and something happens. So with that, though, we are going to look for, are there things that we could put in or take out of that patient, even chronic infections and chronic inflammation, that would help them. From there, though, a lot of times, all right, we don't find those, or we find those and we do remedy those, and then we're going to look over to the hormone side and say, hey, you know, Beth, what are some ways that we're going to help with balance? You know, we've got all the toxicity deficiencies addressed. What are some ways that we could help a patient who's going through that premenstrual dysphoric disorder, which can be very disabling for many women?
it can be. If you look at a normal pattern of hormones, you're going to see progesterone peak in particular, what we call mid-luteal peak. So if day 1 is the first day that you start your period, the mid-luteal range is day 19 to 21 in a normal individual, okay, in somebody that's more typical. And when progesterone drops off, you can get pretty significant symptoms with PMDD. You can get PMS. It's not so much that you have estrogen dominance, it's that you don't have enough progesterone relative to how much estrogen you have, okay? So progesterone is the first place that I would probably start. I did a year or two of psychiatric med management, learned a ton, but looking back on it, realized that so much of what we address from a psychiatric perspective could be addressed from a hormone loss perspective. So I would probably start with progesterone, but we'd want to get a really thorough medical history and health history, family history, and find out what to do. One of the issues with progesterone, a lot of people will recommend that you take it days 12 through 26 or that you cycle it. If you are not trying to get pregnant and you want symptom relief, there is absolutely no reason not to take progesterone every night. It will help you fall asleep, stay asleep. It will really even out your moods. It will lower irritability. It will lower that urge to just cry for no silly reason whatsoever. It will lower the incidence of headaches, all the things that tend to happen when you're in that premenstrual period. So that would probably be the first thing I would start with, but again, I would do a thorough history and look at your thyroid too. That really can control mood. Simple things like vitamin D replacement can make a big difference in anxiety and mood and irritability too. So that's where I'd start.
Yeah.
Thanks.
So I will just add one other thing I thought about is one of the reasons when that progesterone drops is progesterone influences your production of serotonin. Serotonin is one of those little neurotransmitters that you reason a lot of people take Prozac, Paxil, Zoloft. But a lot of times it's not a Zoloft deficiency. In fact, it's never a Zoloft deficiency, but we won't get into that at the moment. A lot of times it's just a little progesterone during those times. Maybe adding a little 5-HTP, which is a amino acid that we use to, what your body uses to make serotonin. You do that, patients often find, well, wow, where did the symptoms go? So it's very a gratifying time to see patients do better with that. So let's move on. Let's see. Next question, but just another reminder for those that are watching now or have just come on. Sanctuary Functional Medicine, Dr. Eric Potter, Beth York, our newest member of the team, certified nurse practitioner, hormone specialist. We're talking hormones. We're going to save a little time at the end. There was one question that we're going to talk about now that's related a little bit to mold detox, but we're going to come back to mold and hormones in a little fuller instant the last maybe 5 or 10 minutes. But this viewer, my OB, wants me to start a low estrogen birth control pill to keep my endometriosis from coming back. Will this help? And she also mentions that she's going through mold detox as well. But will the estrogen help her with endometriosis?
It could, but in my opinion, not knowing your total health history, most of the time what we see is that it's just a Band-Aid. It's a tool in a toolkit that's not treating the root cause. So if what you want to do is prevent the uterine lining from building up, we go back to progesterone. Again, I don't think that you have, I don't really love the term estrogen dominance. It sort of is a thing. I would prefer to think of it as you've got a seesaw that's out of balance. And if estrogen is up here, where it should be, but you've lost progesterone, which happens a good 5 to 10 years before your period stops and before menopause, then you're going to be symptomatic. And if you're dealing with something like endometriosis, that's an issue of the uterine lining building up. So we just simply use micronized progesterone. It's a capsule that you take every night at bedtime. And it prevents that uterine lining from building up and from it proliferating. So
I think this is a good opportunity just to remind viewers, we can't specifically give you medical advice just because if you're not a patient. Now, if you are a patient, we're already giving you medical advice, but if you're not, we want you to get the feedback from whoever is caring for you or give us the opportunity to be a part of your health journey, health restoration journey. In cases like this, what we're wanting to do is give you some ideas. There are other options. A lot of times you'll go to a provider who says, oh, this is it. You do this, so there's no other hope that you're going to get better. One of the things functional medicine brings to the table is there are more options. Having trained in conventional medicine at Vanderbilt, both of us, and having that conventional training, but then seeing, oh, there's other things out there, we can put the best of both worlds, because occasionally we may, actually this may be another good topic with polycystic ovarian syndrome and insulin resistance. We do use some metformin, which is a diabetes drug that helps with insulin resistance. I'll let Beth talk about that more in a minute, but we will use those pharmaceuticals when they're appropriate. But we are going to try to do bioidentical hormones, we're going to try to do nutritional therapies, herbal therapies, often even incorporating essential oils into a lot of therapies to give you more options, and you can sit down and say, oh, well, I like this option better. Here's the risk benefits. We can talk through that, and we've set our practice up so we have more time to discuss that rather than a 10 or 15 minute visit where you have, all right, this is it. Do you want to do it? Yes or no? Oh, okay, nope, I'm out the door and done. No, we're going to be able to have some time to talk through those. So that's how we approach things. And back to what I was going to throw out the next question. We did have a viewer question about polycystic ovarian syndrome and insulin resistance. From a functional medicine standpoint, we are going to look at, there are herbal therapies. Lowering inflammation will improve insulin resistance, and sometimes treating irritable bowel where there's gut dysbiosis affects your ovaries, and you'll see, oh, ovaries, that balance gets better. There are times when we will use some herbal therapies like berberine, not bourbon. That's a whole different ballgame. Berberine, ask us more for the spelling of that, or cinnamon are things that can improve insulin resistance. But from there, I'm going to hand it off to Beth and talk a little bit about some of the things that you can do for women who come in. Tell us a little bit about what polycystic ovarian syndrome is,
Okay.
some of the symptoms, and then some of the ways that we can treat that besides the herbal and things I mentioned.
Okay. So polycystic ovarian syndrome, really a little bit of a misnomer. PCOS, you hear it abbreviated as. For some women it involves your ovaries, and for some women it doesn't. So really what the base or the root of it is insulin resistance. And with insulin resistance, sometimes ovaries are affected and sometimes they aren't. So to more accurately refer to it, we really should be calling it insulin resistance, but the rest of the world knows it as PCOS or polycystic ovarian syndrome. So when you think about PCOS, most people think, oh, those are the women that I see that have hair loss on the scalp. They might have hair growth here or down the neck, bad acne, large tummy, trouble with weight, that sort of thing. And they automatically think that it's a problem with too much testosterone. When in fact, women with PCOS or insulin resistance, the ones that I see are usually 35 and older when they first come, but most of them don't have enough testosterone. But what's going on is their cells in their body is hypersensitive to testosterone. So what we want to do is fix the hypersensitivity to the testosterone. And what we also want to do is we want to lower your risk of heart disease, of type 2 diabetes, and of Alzheimer's. And there are several ways that we do that. Diet is huge in PCOS or polycystic ovarian syndrome, insulin resistance. But a lot of women can't fix things with a ketogenic diet or whatever prescribed diet on their own. So they do need metformin. And metformin will lower their risk of type 2 diabetes. It will lower their risk of heart disease and Alzheimer's. We also want to optimize your thyroid. A lot of women, about 50% with PCOS, will have some of the symptoms that I mentioned before. Some of them will have absolutely no symptoms whatsoever. It's a pretty common thing to see women come in and they just want to get a look at their hormones, get a good look at their hormones, and I'll ask, did you know you have PCOS? And they said, absolutely not. I'm thin, I don't have hair growth here, I don't have hair loss here, I don't have acne. But only 50% of them have that. So, and the other thing that we typically want to put you on, if you're not trying to conceive, is spironolactone. It's a pretty weak diuretic, but what it does is prevent inflammation in the lining of the arteries. So as you get older, it's another tool that we use to lower your risk of Alzheimer's, heart disease, and diabetes. So those are the three things that we treat most often when we're looking at PCOS. Of course, the diet is still really important. Some people really worry about metformin, but a lot of people don't know that metformin has anti-cancer properties. So it's a lot of good studies out there and good research showing that. So you see women with PCOS have infertility, and then you see other women with PCOS have no problems with fertility. If you are on metformin, when you get pregnant, you want to stay on the metformin throughout the duration of the pregnancy, because the metformin itself is going to lower your risk of miscarriage by over 50%. It's going to lower it to under 10%, and in some instances it's going to be a lower risk of miscarriage than that of the general population without PCOS. You often see women with PCOS also have not enough progesterone, and that's an easy thing to address too, as we've talked about. Really rewarding to take a patient with PCOS that's been really unable to lose weight, that's been unable to fix hair loss or hair growth or acne. And in some instances you can help with fertility, which is always a win-win situation. And metformin will also help lower your risk of gestational diabetes. And having gestational diabetes puts you at higher risk to develop diabetes outside of pregnancy too. So win-win situation with those patients quite often.
So just because I'm always fascinated at the way that our gut microbiome, bacteria that live in our colon, are connected to our health, I will mention that one of the interesting studies that came out in the last year was a study where they looked at immediate versus extended release metformin, and the extended release actually had a greater sugar lowering effect in diabetic patients. And the hypothesis, the theory behind that is that the metformin is actually having a greater effect on the bacteria in your gut. So I'm looking forward to, as we get more research, are some of the medicines we use, like in metformin in this case, is it treating some gut dysbiosis, improving the metabolism of our gut bacteria, that then leads to these effects downstream for the insulin resistance. So is our insulin resistance actually a gut bacteria problem? So anyway, that's yet to be fully answered. So we touched a little bit on hypothyroidism in a number of different questions here, but one of our viewers just asked about sharing our thoughts. So I'm going to share a few thoughts from my functional medicine approach, and Beth will share hers from the hormone approach. Our treatment is very similar in that there's not much difference, but one of the things I want to first look at is what is causing, a root cause. Functional medicine says, what is the root cause? Why are you having thyroid issues? We have patients who come both with Hashimoto's, where their antibodies are attacking their thyroid, and we have some that come without those antibodies, and it's more of the worn out thyroid. Sometimes we have patients who have had their thyroid removed for hyperthyroidism, or a few patients with thyroid cancer. But first of all, we're going to look at root causes. So if it's Hashimoto's, where autoimmune attack on your thyroid, are there foods, gluten, dairy, or some random foods? Have a patient who was sensitive. IgG testing showed that she was sensitive to eggs. We cut eggs out of her diet, and we've seen her antibody levels go consistently down. Occasionally we'll see patients' antibodies go completely away. Those are the ones who are lower levels and maybe just diagnosed in the last 1 to 3 years. Some of the patients have said 20 years of Hashimoto's, it's going to be a little more difficult to reverse those, but we have seen at least those antibodies levels going down. We will look at optimizing the thyroid with selenium, making sure your iron, selenium, vitamin A sufficient. Iodine, especially we're in a little landlocked area where we don't get a lot of great seafood, and there's a lot of danger in eating seafood that has mercury, which then can damage your thyroid. So we see a lot of low iodine, and boosting that up a little bit to appropriate levels helps your thyroid work better. And then from there, if you have thyroid antibodies attacking your thyroid, supplements like ashwagandha can actually have been shown to lower that, and there's some other therapies we'll use. So we will try to optimize what your body is doing, but then we will look at supplementing either with a pharmaceutical or a natural thyroid medicine. So the pharmaceutical, you can either get T4, which is the less active but greater produced hormone from your thyroid, or T3, producing smaller amounts but maybe 100 times more active than the T4. Typically pharmaceuticals, Synthroid, those type of things, will use the T4. A number of people do great on that. Although I have patients who come to me and say, I want to do the natural version. Then we will look at some other products that have a mix of T3 and T4 that have come from animal versions. Those will be purified, measured out, and we will utilize a number of different brands to treat patients. So with that, sometimes we'll even combine, because we will keep pushing, finding what the right combination is. I have patients who take some of the natural, but then they'll take a little bit of the synthetic T3 just to boost up things a little bit. And they find that they feel great. We use both symptoms and labs, so we don't just say, oh, well, your TSH is great, we don't need to do anything else. We're like, what is the right TSH for you? Just because the TSH shoe size fits this person over here and they feel great, the TSH for you might be 1 or 2 points off, or 3 or 4 points off. I have a patient who runs on the far upper end. She does wonderful. Doesn't want to take anything medicine at all, but she's an aerobics instructor. Does wonderful with that. Others, if I don't push them down a little bit lower, they're going to have constipation, hair loss, fatigue, depression symptoms. So from there, though, Beth and I both work on these together, is looking at some of those. The way we would approach things a little differently than a conventional would, beyond what I've already said. I've kind of stole a little bit of the answer for me, but from there, what else in trying to get somebody's thyroid down to the right level for them?
I think there are a number of factors to look at. In traditional medicine and conventional world, depending on who you talk to, a diagnosis of hypothyroidism is solely based on your TSH level. TSH can tell you some things, but it doesn't tell you the whole picture at all. So you can have a completely normal TSH, say of what some people call normal at a 4.0, okay? And so you get put on Synthroid or levothyroxine. That is strictly T4. That's all it is. The problem with giving you T4 is that your body's got to then take that T4 and convert it to T3. so that you get some symptom relief from things like cold hands, cold feet, dry brittle hair, skin, and nails, word finding difficulties, fatigue, depression, and weight gain, constipation too come along with that. So about 15 to 20% of the general population at large are not great converters of T4 to T3. So what will happen if you get something that's only T4 is you'll get great levels of T4, which is what will push your TSH down. But unfortunately, because you're not converting T4 to T3, you're not going to get the symptom relief. And also, your free T3 level, which is responsible for so many of those symptoms, is going to really fall. So a lot of men and women will find that when they get put on Synthroid or levothyroxine, which is the T4 only product, that they get more symptomatic, and so they keep going back in for checkups to say, I just don't feel any better, or I can't really tell a difference, or sometimes I just feel worse. It's because that T3 portion of things is not being addressed. And at the age of about 40, we in general stop converting as well as we did before, the T4 to the T3 portion. So what we do, there are some patients, I would say for me 1 to 2% maybe, that do well on levothyroxine and Synthroid alone. It's pretty unusual to do well on that alone in my experience. We can use Synthroid or levothyroxine as long as we add Cytomel, which is the T3 portion of it. So it depends on dosing too. For some patients, they need to take that T3 2 to 3 times a day to get relief, because they'll really start to tank late afternoon. And for most patients, I would say I really prefer the natural desiccated porcine thyroid hormone in the form of Nature Thyroid or NP Thyroid, Westroid. There's some small differences. There was a filler added to a few of them years ago that has really impacted how patients absorb the T3 portion of it. My goal in treating hypothyroidism is to give you symptom relief first, which doesn't tend to be the hardest part, believe it or not. I want to optimize your levels so that we then lower your risk of heart disease, Alzheimer's, and diabetes. That's really my #1 goal. So even though someone may look at your labs and say, oh, you fall within a normal range, well, normal and optimized are 2 different things.
Yeah.
And so we, I think, collectively are going for optimize, for disease prevention, because you don't want to, as you get older, you don't want to add another diagnosis every 5 years. You don't want to find out your blood sugar's trending up, when you turn 40, and you don't want to find out that your blood pressure starts trending up at the age of 45, and then your cholesterol starts trending up at the age of 50, and we don't want to add a diagnosis until we just feel absolutely rotten and can't participate in life. Yeah. So what we aim to do is optimize your health and offer you disease prevention. Again, fixing the symptoms is really not the hard part. No. Optimizing is what takes a little bit longer. No.
So what Beth said is absolutely on target. So I'm just going to add 2 things that we always have to keep in mind. One, again, we are not treating you. If you're not a patient, we're not treating you. So I strongly advise you saying, oh, I'm going to increase my thyroid medicine on my own. You need to talk with your doctor. We emphasize our patients, don't hide things from us. If you didn't take your medicine, if you forgot something, if you went off the reservation on your gluten-free diet, let us know. We can work with you. We're not going to slap your hand on those kind of things. But if you don't tell your doctor, you change things, then you go do lab tests, they're going to be confused and they're not going to be able to take care of you well. The second thing, I was reminded by someone I met yesterday who talked about they had been poorly controlled. They had had their thyroid taken out. They'd been put on thyroid medications for 6 months, just kept increasing the dose, couldn't get it under control, and nobody could figure out what was wrong. And she said, oh, I looked at the bottle and it said, don't take with vitamins. She went back to the pharmacist and said, why don't I take this with vitamins? Well, because the iron will cause you not to absorb your thyroid. So she'd been taking her thyroid medicine and her multivitamin together. It wasn't going to help much. So that can also go for coffee, tea, and milk. If you
or apple cider vinegar or lemon juice in your water.
You want to take your thyroid medicine, where it's natural or synthetic, either one needs to be with water, and you need to wait. You do not need to go drink your water and then start eating your breakfast. So that is something you need to keep in mind. That is a tidbit you may want to put in use.
Yeah, wait those 30 minutes, because what you'll often see is the T4 will absorb kind of okay to lower your TSH, but that T3 is not going to absorb, and you're not going to feel any better. So.
So I want to take the last few minutes to talk about mold toxicity and how it affects hormones. But for our prior, someone who might be coming on just now, this is Dr. Potter with Beth York, our certified nurse practitioner hormone specialist. We are from Sanctuary Functional Medicine, where we try to help patients live healthier, more abundant lives. We've been talking about hormones. We've touched on premenstrual dysphoric disorder, polycystic ovarian syndrome and insulin resistance, hypothyroidism, endometriosis, the benefits of hormones for the postmenopausal and also for the perimenopausal as women's hormones are decreasing. So there are a lot of things that are further back in this if you're watching this recorded later. But for now, let's talk a little bit about one of the things that we're seeing in a lot of patients right now is mold toxicity. So this is an instance not where you're infected, not where you are allergic and sneezing, although you may have some allergies secondary to the toxins, but these are where toxins are produced by these mold that get into your body and trigger immune reactions and hormonal reactions. And a good way to think about what can mold do to your body, it's easier to say this. Is there anything it doesn't do? I've not really found a body system it's not affected yet. But for today, I want to talk a little bit about hormones. So I want to start us off and then talk to you a little bit about Beth coming on board. One of the things we're excited about is kind of mold 2.0 therapy. So we apply a Shoemaker approach. Dr. Shoemaker is well known in the mold toxicity world. But one of the things we're looking at is how to, you really can't fix someone's hormones while the mold toxins are still in their body. But how can we balance that and help people symptomatically until the mold toxins are removed, their body starts functioning better again, and then we can back off that support. It's kind of, you don't use if you sprain an ankle, use a crutch, 2 weeks, 4 weeks, 6 weeks, but once you start walking better, you take that crutch away, or you maybe use it a little bit less. So that's what we're looking to do. How do we help patients in that 1 to 6 month range where we're detoxing and they're like, my hormones messed up, I can tell my progesterone, my estrogen, testosterone symptoms are crazy. So we're going to talk a little bit about that, but one of the ways... Alright, testosterone loss, which may be one of the reasons why a lot of patients with mold toxicity have trouble building muscle, or they start having what Beth mentioned earlier, sarcopenia, where your muscles kind of fade away.
Yeah.
So with that, let's talk a little bit about, we're still sorting out this approach. It is something that nobody else is doing, and we are going to do our best to be the leaders in this. So for a patient who is coming to us with mold toxicity and their estrogen is a little higher, their testosterone is a little lower, there's some herbal therapies that can slow that process, that enzyme down, but also we're going to be looking at using some of the bioidenticals. So kind of talk a little bit about easing into a bioidentical, not quite the full speed that we might do with someone who's free of the mold toxin, but just a little bit about how we would approach that.
Well, I know a lot of patients that when you start to detox them from mold, they feel horrible. They're exhausted. Some of them feel worse after they start detoxing than they did when they came to you. So one of the things that can ease that is a low dose of testosterone. And a lot of people think you can only get testosterone through shots. A lot of people also think that testosterone causes blood clots or heart attacks or strokes. Or men in particular ask me all the time if going on testosterone is going to cause them to develop breast tissue. It will not, by the way. But it's in an effort to not just get their hormones back and get their body functioning optimally, but to give them some symptom relief as they start the detox process. So it will help hugely with mental clarity, with energy, help with fatigue, and also hopefully help them fall asleep, stay asleep, and have a little less memory loss.
Yeah.
So
that is just a glimpse of what we are thinking of terms of mold 2.0. Not your regular old mold therapy where you kind of have to tough it out because it is a tough process. but to help patients with hormone problems, help them balance histamine issues, which is another big issue when histamine is released as you're detoxing from mold. So we look forward to applying that to our patients and see them feeling better. But again, we're going to finish up for today. We are going to, though, mention here in the next 2 or 3 weeks, we will be doing a talk on mold, where my physician assistant, Hans Hinterkopf, I will spell that for you later, but Hans has been with us over a year now. One of his big interests is mold toxicity, so he helps a lot alongside me as we have a team here. This is a team approach. You're getting more than just a single person taking care of you. You're having the 3 of us and then our nursing staff and our administration staff helping with your care. But Hans and I will talk about mold toxicity and its effect also on one of his other favorite topics is brain health, helping patients recover from Alzheimer's or that early cognitive loss. Type 3 Alzheimer's is now considered one of the kind of a catch-all term for toxin-related Alzheimer's, which mold toxicity is one of the big things. So stay tuned for our little Facebook post about when we're going to be doing that. It's probably going to be in 2 weeks, but we just got to check on scheduling. So I look forward to talking to you more then. If you have more questions about how you can get care here at Sanctuary, Stephen is available at the 615-815-5941, or our website, sanctuaryfunctionalmedicine.com, has a lot more information there as well, and you can send him an email through that system. Again, thank you for joining us today. Sorry about the little technical difficulties. No matter what you try to plan ahead, always little things happen. So we look forward to helping those with chronic illness live a healthier, more abundant life here at Sanctuary Functional Medicine. Thank you, and you have a blessed week, and see you soon.